Today's module is on tennis elbow and golfer's elbow. And I've purposely brought up a sleeve to try to help us understand where these are. These are also called medically lateral epicondylitis for tennis elbow or medial epicondylitis for golfer's elbow. It's not really an itis according to more contemporary understandings of these disorders. It's more of a lack of function of the tendon. Nowadays we think more in terms of tendon cells, the so-called tenocytes, are not functioning the way they should. Sometimes it's called an osis because they look disorganized and thickened under microscope or MRI scan, and yet even though they're thickened, they're less effective at doing what they're supposed to do. Lateral epicondylitis, as the name implies, tennis elbow, is at the lateral epicondyle, and medial epicondylitis is at the medial epicondyle. The medial epicondyle has a number of wrist and finger flexor muscles that originate from where it is situated just above the elbow. Sometimes it's also called the common flexor origin. And typically when patients have a medial epicondylitis, they'll have difficulty with activating these muscles, such as flexing the wrist or flexing the fingers. Lateral epicondylitis, tennis elbow by contrast, has the common extensor origin. So the muscles that extend the wrist or extend the fingers are originating at the lateral epicondyle. And it's often painful for patients to bring their wrist into extension or their fingers into extension with tennis elbow. Early diagnosis is important because early treatment can be very helpful. Sometimes it's as simple as just putting a forearm band around the elbow, but I'll show some other things that we sometimes use once we've made an accurate diagnosis. Patients are often grateful to have this diagnosed as it helps them return to function, such as their work or to their other activities earlier than otherwise. Okay, so for tennis elbow and golfer's elbow, I've already discussed where those are anatomically. Interestingly about tennis elbow is I've had only one time in my career somebody actually playing tennis and getting tennis elbow. It's generally a working man's diagnosis. It's people who do real work for a living, turning wrenches, mechanics, roofers, people like that. You can get it from trauma. For example, in a whiplash injury, a motor vehicle crash, maybe the elbow hits the car door, or for one reason or another, the patient does not only have neck pain, but seems to have pain localized to the medial or lateral epicondyle. If we look at exam, again, I would start with the neck and the shoulder, very briefly. But for example, if there's weakness of the scapular muscles or poor posture, I generally look at treating that in addition to the more distal problem. For lateral epicondylitis, which is really an epicondylosis, as I mentioned, it's really sort of a thickening of tendon rather than inflammation. The lateral epicondyle is here. It's the common extensor origin, so the wrist and the finger extensors originate in this area. Wrist extension, you'll pick it up either before your neurologic exam or with your neurologic exam. When you do wrist extension, that's often painful and weak for the patient. Finger extension, also causing pain in this area. You can stretch the wrist extensors, so we put them in a passive stretch, and that extra stretch on the tendon will make it worse. Often I pronate them at the same time. You can test your diagnosis further. For example, if you simulate putting a forearm band, one of those Velcro bands, and have the patient bring the wrist up again, hold it, and that often relieves their pain because, again, you're not putting as much stress on the wrist extension apparatus there, or the extensor origin. And similar things hold for golfer's elbow. Again, I've never seen it from someone playing golf, but it's the common flexor origin. There's the medial epicondyle on the inside of the elbow, and multiple muscles, wrist flexors and finger flexors, originate here. So when the patient flexes their wrist and activates the wrist in flexion, they'll get pain in this area. They'll also often have a focal tenderness here. And again, if you try to relieve that by simulating having a forearm band, they often do better. There's some things in your differential diagnosis. There's something called radial tunnel syndrome, which usually has tenderness a little more distal to the lateral epicondyle, and but can be confused with lateral epicondylitis. It's believed to be a subtle entrapment of the radial nerve as it courses through the elbow area. And for medial epicondylitis, or osis I should call it, or golfer's elbow, you can get an ulnar neuropathy, which is between the medial epicondyle and the olecranon in the cubital tunnel. But that usually presents more with neurologic findings. Treatment, in addition to more proximal treatment and using a forearm band. So this is a nice tool that we use in our clinic for patients with these disorders. It's called a flex bar. And what we do is we have the patient, let's say we're treating the right lateral epicondyle here. I'd have the patient hold this like this and then bring the wrist like that. And then I have them twist this way. Now what that does is it does activate the wrist extensors here, and it puts some extra pressure on the lateral epicondyle. But as they bring slowly, holding that one the same, and they slowly bring the wrist back to this position, what happens is that they're still activating the muscle, but they're doing what's called an eccentric contraction. Eccentric contractions for muscles are when the muscle's lengthening but still activating. So this is, if I'm doing a biceps curl, this is concentric. And then if I'm going to pretend this is a barbell. This is concentric and this is eccentric, right? The muscle's lengthening, but it's still active. It's not like I'm using the triceps. I'm still using the biceps, but I'm letting myself down slowly. Eccentric contractions are very interesting in my field because they're often the cause of acute injury. The hamstring tear of the athlete running. The hamstring's lengthening, but it has to contract. So it tends to tear muscle, but it's also the cornerstone of muscle and tendon recovery. So for Jennifer's case here, when she's doing this, and she starts to slowly bring it back this way, she's eccentrically utilizing the wrist extensors. And that actually can tend to help build up the muscle, or really the tendon, and overcome this tendinosis and make the tenocytes, the little cells that make up the tendon, align better and become mechanically more effective. So it's sort of a non-invasive, relatively simple way of helping patients with these injuries. I have all kinds of sizes in my clinic, as you can imagine. If it's too much for the patient, you'll make them worse. So there's a yellow and a red and a green and a blue. This is one of the easier ones. And if that doesn't work, we often do PRP injections in this area. We used to do cortisone years ago. I never liked it. It always wore off. It's very rare to get surgery for this. Usually we can treat it without a need for surgery.